Today, I'm going to focus on sort of the foundations of medication adherence and the role that behavioral science can play in helping us understand it and think about solutions. And to that end, I think usually the first place we start is to make sure we're all on the same page and talk about what do we mean when we talk about medication adherence. And one of the things that I think is important to remember is that fulfillment is the first step when we talk about medication adherence. And that means that the patient is actually fulfilling the prescription that the provider has written. And it's actually a fairly understudied area. It's a place where we don't have quite as much data as in looking at persistence and compliance. And so compliance is sort of taking the medication as prescribed. So it counts for both taking the dose that the provider has written, but also at the prescribed intervals. Whereas persistence is something that we measure over a period of time. So it tends to decline with time, but we might talk about persistence for a period of 6 or 12 months when we're talking about a chronic medication, or we tend to hear it a lot when we look at antibiotics. And did someone complete the full course of antibiotics? So did they take it over a period of time? Interestingly, there is not a single definition for optimal compliance when we talk about these, but typically what you will hear is for people to talk about sort of 80% compliance as being the target. And so when we look at this, I'll use U.S. data a lot throughout the presentation, just because it tends to be where most of the published literature has come from and provides us with a nice sort of unbiased source of information. But despite the many problems that I'm sure you're all aware of with the U.S. healthcare system, this is not something that is unique to the U.S. And this data is actually fairly representative of other countries. And so when we look at sort of the information, what we see is that at each step in the process, adherence tends to decline. So from the point of prescription, there's a decline to getting it filled, and then there's a persistence after that. And so where we kind of end up is this metric that you'll hear cited a lot, which is that only about 50% of medications are taken as prescribed. And the more doses that are part of that prescription, the lower adherence tends to be. And it's estimated that about 75% of U.S. adults are non-adherent in one way or another. And as a technology person, I think there's sometimes a lot of hope that technology can solve problems. And we did see some benefit from e-prescribing, in getting more scripts filled. But it certainly hasn't eliminated that challenge. And so, there's just a real opportunity here at every step of the process for us to help patients and do better. And so we think about the importance of this question, and I think sometimes we take it for granted that it's an important thing, but when we start looking at the implications, the costs are enormous, and sort of in the UK, those numbers are, in Europe, those numbers are sort of about 200,000 premature deaths, about 125 billion in excess healthcare services costs. And it's not just healthcare costs that we get concerned about here. It's also sort of costs around this broader economy. So will be things like productivity, and play into that as well. And productivity costs are actually estimated to be about 2 to 3 times the direct medical costs. So that's an important element of this, but we tend to have a lot more data on the healthcare costs, and they really are that mortality rates are higher for patients who are non-adherent. The costs total are higher, and a lot of that is driven because patients who are non-adherent to medications are more likely to end up hospitalized. So they present at a later, more costly point in the care process. And it's estimated that about 10% of hospitalizations are really driven at their core by non-adherence. And so, there's just this enormous sort of economic and societal cost to it that we really can quantify and look to address and drive down. So when we kind of look at how that might play out in a single condition, as adherence goes up, costs tend to go down. So even though the patient is going to be spending more on medication because the drug costs will go up, the total medical costs go down. And so that's a really important, we can quantify that and really see it. And so I think it also helps us remember that we don't have to get to, although we would like to get to 100% adherence, at every point of improving patients' adherence, small differences really do make a difference in driving that cost, and we can just keep making incremental improvements along the way. So I think the question then is sort of, I come from the digital health space, as was mentioned, and so I spent a lot of time talking to investors and having to answer this question about what's the ROI, right? So for every dollar we put in, what's the return? And in the U.S. healthcare system, people are typically a self-insured employer. We're looking for about a 3x. So for every dollar spent, I want to get at least $3 in return. And so when we look at the data on what happens when we invest in medication adherence, the benefit ratios here are just remarkable. So for lipids, it's 1 to 4, and at hypertension, you're getting a 14x return. So for every dollar spent, you're getting $14, cost benefit. And so I think it's really important to remember that there are, in the healthcare system, there's certainly no shortage of challenges that we face and no shortage of places that we can put resources. And so I think it's really important to remember here as the sun starts shining in my eyes, sorry for that, that we can really see a benefit by the dollars that we invest here. And that's a wonderful, wonderful thing. And so as spending goes up, this is a place where the dollars spent have a clear return. So when we look at sort of what is going to be driving adherence and sort of digging into that core causal analysis, one of the places we start is with self-reported data. So there are a number of data sources that we can turn to for adherence. We can gather data from patient report. We can pull data from health system records for places where there's an insurance system operating, like here in the U.S. We can use claims data. But when we look at what patients report as their reasons for non-adherence, forgetting is the most common reason that they ran out. And of course, you can imagine there may be a whole bunch of reasons why they ran out that underlie that. But I think what is important to realize here is that these are the reasons patients report, but there can be a whole bunch of other things that underlie this. And it doesn't have to be just one reason, right? So you can see here that there's a number of reasons that patients commonly report, and patients can report more than one reason. And while, again, this is U.S. data, this is quite representative of what we would see in many other countries. So this is not while we sometimes like to simplify in discussion and say, patients don't follow the directions they're given, it really is not a simple problem. There's a lot going on here and a lot that we can, and that's a great thing because it provides a lot of opportunity for us to do something about it and intervene, which is, of course, always our goal in public health and medicine. So the World Health Organization has actually put out a really nice model that really describes that multidimensional nature of adherence and that it is not this simplistic problem. So when we talk about sort of bottom right there, the condition-related factors, that can be things like the fact that patients who have more than one health condition, the polychronics in particular, the presence of those comorbidities, though that plays into a patient's adherence to a medication or medications. The lack of symptoms associated with some conditions plays into adherence. And so we tend to hear that a lot in things like hypertension and hyperlipidemia, where patients feel fine. And so that plays into the sort of mental model and the mindset around adherence to a medication. When we think about therapy-related barriers, those are things like the drug side effects, the complexity of the drug regimen. So if it has to be taken in certain ways or at certain times, if the medication has storage requirements, so if it requires refrigeration, that may be challenging for some patients. How it has to be administered. So a patient who has a fear of needles may not do well with a medication that has to be injected. So there are therapy-related factors that can play in. The patient-related factors are those things the patients reported, but they're also things like having a low health literacy rate and not understanding elements of the prescription protocol that they've been given. It can also be their preferences and their beliefs about their condition. And so we tend to see that a lot in conditions where patients may believe that there's nothing that can be done for them and they don't believe the medication can help. So the patient beliefs are a part of that patient-related factor, as well as things like forgetfulness and health literacy. On the socioeconomic side, those are things I think everyone is familiar with around poverty, unstable living conditions, right? So do you have your medication with you? If you are sleeping in a different place every night, that may not be the case. And sort of having a support structure is another element of those social and economic factors that play in. We know that patients who have strong social support tend to do better at adherence with all care regimens, not just medication. And that the healthcare system and health team play a really important role here. So the quality of the interaction between the provider and the patient, the procedures for discharge from a facility, the out-of-pocket costs, how difficult or easy it is for patients to get a refill will play into that. And you may have been reading the news in the US. This has been a very hot topic because many patients refill their prescriptions through the Postal Service. And when the Postal Service is not operating as patients and companies had expected it to, there can be delays in getting medications that play into that. And so there really are a lot of different factors that can be playing into the adherence for a single patient. And so to sort of point at patients and just say they forget or they don't listen really ignores this entire structure that operates around them that also contributes. And so this multidimensional model really is intended to capture the complexity that is medication adherence for our patients. And just to sort of give you a sense of how much of that, the patient certainly plays an important role, but the research indicates that relatively, it's actually less than half, about 40% of it is around the patient. The provider has an enormous role to play here. So this research actually separates out the healthcare provider who's doing the prescribing from the pharmacist who is filling the script. And I think that is important because both of those healthcare providers have an opportunity to communicate with the patient and to play an important role in adherence. And so I think a lot of times providers give information to patients, but the research indicates that information is fairly limited. Patients may not understand it, and it may not sort of align to the values and priorities of the patient, and really enhance their motivation for adhering. And so there's a real opportunity for communication and improved communication to play a role here. And that's really why this program is so great, because it's an opportunity to improve those communication skills and align to the patient motivation to drive adherence. And what we call that in the research literature is something called patient-centered communication. And patient-centered communication plays a really important role in adherence, not just to medications, but into care plans in general. So I spent a good portion of my career working with patients to get them to engage in lifestyle behavior changes as part of a care plan. And patient-centered communication is equally an important part of that process. And the reason we know that that's important is because about 50% of patients will report leaving an appointment with their healthcare provider and report that they do not understand what they were told. And the research shows that the more positive the patient reports their relationship with their provider, the more likely they are to be adherent. And so when we talk about patient-centered communication, that exchange of information of telling the patient, I'm going to write you a prescription for this, and you need to take it twice a day, and you should take it with food, that's an information exchange. But it's the other pieces of it, responding to the fact that the patient may be afraid or confused, the fact that they may be uncertain about their ability to afford a medication, and really giving them the self-efficacy and the confidence to go forth and manage their condition are all part of patient-centered communication. So it's not simply an exchange of information between the patient and the provider, but it is and that's the other important part of it, is it's not just the provider giving information to the patient, but also receiving information from the patient that may lead them to prescribe a different medication that has a simpler delivery regimen, or manages something else related to that. So one of the things I always sort of think about when I talk about this is that, when my mother was diagnosed with cancer, I think there's we take for granted that patients know that there are side effects associated with chemotherapy. But my mother's provider never had a conversation with her about the specifics of those side effects or what she could do to manage them. And so I was the one who went and did the research on what are the effective strategies for her to manage the side effects of her chemotherapy regimen. And she actually mentioned it in passing to the nurse one day at a follow-up appointment. And the nurse was just sort of said, "Oh, that's really great. Where did you learn that?" And so I think sometimes it's important to realize that the patients may not have that knowledge, and they may not know that there are strategies out there for managing side effects, right? So if a medication has a side effect of having someone, it's interfering with their sleep, and you can recommend that the patient take it in the morning instead of the evening. I worked on a medication where one of the known side effects was that patients became constipated. And so, acknowledging for patients that may be something they experience, and recommending that they increase their water intake. Those are strategies about helping patients enable their self-management, and fostering a conversation with them to navigate through that. So that shared decision making is really about having a shared goal and responsibility with the patient for managing their care. But it is a multifaceted process, and that will be different for each patient. And so there will not be this is the strategy that you should use for every patient. It will be a process of evaluating the circumstances for each patient, and may require you to try things at different appointments to see what's working and works for different patients. So there's certainly not a one size fits all here. So much like the conversation in broad medicine, behavioral science and patient-provider communication are by definition a personalized strategy. And so you may be able to share strategies across patients, but there will not be a single strategy that works for every patient. And so I think it's important to also talk about the role that our health systems play, because we don't want to say that this is the responsibility of two individuals, the patient and the provider, without talking about the role that the health systems play. And I also talk about it because I'm sure that many of you who are listening are thought leaders and institutional leaders within health systems, and have an opportunity to make decisions from your leadership positions that can increase adherence to care protocols and medications. And so as some examples, health systems direct the length of an appointment and the duration of treatment. And so the more time that a provider has to spend with a patient, the more opportunity there is for shared decision making. which isn't to say that every appointment needs to be an hour long. I know that, at least here in the US, we're seeing these shrinking conversations, but there may be more complex patients may require a different visit duration. It's things also like when the first follow-up appointment is scheduled post-discharge is actually correlated with medication adherence. So the sooner a patient has a follow-up appointment after discharge, the more likely they are to adhere to their medication regimen and their care plan in general. And so I think the structural changes that can be made that facilitate that can help. The out-of-pocket costs that the patient carries, and the ease of filling a prescription all play in and are all factors that the health system can contribute to. But of course, the patient is the center of this medication adherence conversation, and their behaviors are really a great opportunity for us to think about what we can do differently. And so when we think about this, missing a dose is one of the most common non-adherent behaviors. We look at them sort of not self-reported by the patient. And what's interesting is that about half of patients don't understand their dosing instructions. But it may also be when they miss a dose, not that they didn't understand it, but their beliefs may matter. And so they may not believe that it matters that they take every dose. They may not believe it matters if they miss a dose. They may be confused about what happens when they do miss a dose. When they remember, should they take it right away? Should they wait until the next time they're scheduled? Should they double up, right? Those are all things that someone can do when they realize that they have missed a dose. And patients often sort of have their own beliefs about what they should do in that circumstance. Patients who come from families where there's a family history of a condition may also have beliefs about the roles that medications can play. And so they may not believe that medications will make a difference. They may believe that the outcome of this condition is sort of a foregone conclusion. And so the conversations that we can have with patients about the role that a medication can play in changing the course of a disease really does make a difference. And so I think part of that is to dig past the surface level behaviors that patients will report about medication adherence to really get to the underlying reason. So if you've kind of seen those pictures in presentations that people give where they have the iceberg and just a little bit of it is sticking up above the waterline and there's a big chunk of ice underneath. I think medication adherence can often be thought of with that kind of mental model that when the patient tells you that they forgot, there may be a whole bunch of other things that sit underneath that we can dig into. Obviously, affordability is a big piece of this, but it's not the only reason. And so I think to just point to the cost of a medication as the reason does miss a bigger part of the picture. That said, there is a linear relationship between how much the patient has to pay out of pocket or their cost sharing component and the level of adherence. And about 1 in 4 patients does have a hard time affording their medications, not just here in the US, but around the world. And so, that does play into this, of course. And I think the other thing that comes into the medication adherence question is that patients may be making decisions consciously to not pay for a medication because they need to put those dollars elsewhere. And so it may be a very rational decision to be spending money on rent or food instead of a medication, and understanding if that's a reason, how we might address those other social economic factors to put the patient in a position to be able to afford the medication can make a difference. And we're seeing some programs like that in the US, and I'm sure in other countries where when patients are put into a stable housing situation, they are more adherent to their care plan and able to have better health outcomes. So I've mentioned a number of times that there are layers to what we talk about in adherence to any care plan. And so we have a number of models for that in behavioral science that really look at the individual being nested within these other layers. And so the interpersonal is, the family and the role that the family plays. And when I worked in weight management, we would talk all the time that when the wife was the one losing weight, there was always ice cream in the freezer and chips in the cupboard. But when the husband was losing weight, those things weren't in the house at all because he had the full support of his wife and she wouldn't buy any of those things in the grocery store, which of course I realize represents a whole bunch of sort of gender norms that may not play out in every situation. But it was a common theme that came up as the role that other members of the household play in supporting decisions. And so that also plays in to things like medication adherence. Family members may have beliefs about medication or about the health condition that play into that. And we've talked about the organizational, the community, right, the hospital and health system. That could also be the employer, right? So whether or not, if someone needs to take a medication at a certain time and they can't get a break from their job at that time to take the medication, that organizational infrastructure can be a barrier to adherence. So we really think about all of those playing a part in this complex, multifaceted dynamic that's happening around medication adherence. So to give you a more sort of concrete and specific example of what this may look like, when HIV treatments became available and we looked at what happened with the introduction of ART in the US in 1996, right, we had a medication available, but adherence was fairly low. And so some of the reasons that we discovered when digging into that specific example were things like, the stigma associated with the disease led a lot of people to they had sort of be reluctant to admit that they had it because it had so much stigma. And therefore, you have to admit that you have the condition before you recognize that you need to take the treatment. And I think because the HIV had been viewed as a death sentence for so long, I think there was this sort of, again, coming back to that belief that, the outcome is preordained, that people were not convinced that taking the medication would make a difference, which of course was not the case at all, right? That the perception that the regimen would be helpful, it took some time to kind of take hold. And sort of having the attitude that this is possible, right? That changing, doing something different can make a difference. And having that perception of being able to do something that changes the course of their condition really played in. And so I think it's important to realize that it's not just our chronic conditions like diabetes and heart disease where this happens, but also plays into infectious disease treatment management as well. So across a range of conditions, do we see these adherence models and these patient belief models play in? So sort of thinking about the strategies that we can deploy for improving medication adherence, there are these strategies across the spectrum of patient, provider, and broader system, right? So we can design insurance programs for lower co-payments to improve adherence. The greater care coordination we have as patients move from inpatient to discharge, and the ease of connecting into that will play a role. I mentioned e-prescribing as a factor that mattered as well as simplifying our medication regimens. So those can all play into it as well. In terms of the structure. On the patient side, I think we've sort of been talking about this patient-centered communication, and you all are so fortunate that the subsequent speakers are going to dive into this and that they're just incredible experts at that topic. So I don't want to steal their thunder too much, but I think it's important to realize that patient communication, the education, it is how and what, but it's not just the provision of knowledge. It is sort of the giving of information and what you say matters, but how you say it matters as well. And so that patient-centered communication involves understanding the patient's views, what motivates them, what barriers that they might have to adherence. And doing so and having that two-way conversation allows you to create a mental model of what might be driving the patient's adherence. And you can use that mental model to then think about what strategies to deploy. I think reminders have gotten a lot of attention in recent years. As ability to sort of send an SMS or text message alert to remind patients to take a medication. And there's some indication that those may be helpful. But as my husband likes to remind me all the time, nobody likes to be nagged. And those repetitive reminders can quickly become feel that way to patients. And so I think we're seeing some evolution of a more personalized strategy that may be more effective in that. But I think that the devil is certainly in the details in those reminders. They may be more effective at inflection points in care where a dose escalation may happen or circumstances may change that really allow us to tailor the messaging at a deeper level. Again, that personalized behavioral change strategy. So that mental model that we create through the patient-centered communication and that two-way dialogue allows us to, sort of really, I think of it as sort of, it is using our best inner scientist. And I think oftentimes we do this without realizing that we're doing it, that we have a model in our heads of why a patient is behaving a certain way and what may be driving it. And by using these mental models, it allows us to identify a likely approach and to test whether or not that approach works. We mentioned sort of you might have to iterate a few times. So it may require, tweaking your strategy for an individual patient along the way. But if you think back to sort of, you may believe that the patient does not believe that this medication will be effective. And so if that is your hypothesis, that the patient's background beliefs may be a barrier to adherence, or their beliefs about the side effects being too awful, right? Then you would construct your behavioral adherence model and intervention around addressing those medication beliefs. And then you would see if their adherence changed. And if it didn't, you might adjust and think about what other barriers might be existing or what things might facilitate adherence that you could reinforce. And so by sort of having a model and knowing what the model is, it helps point you to the strategy that you may want to deploy for that patient. And the great thing is there are a lot of behavior change elements that we can deploy as part of one of these interventions. So, of course, making sure the patient has accurate information is important. And so that's the provision of knowledge, which is an important part of the conversation. And I don't want to discount that, particularly in this era where lots of misinformation is available and being circulated for patients, making sure that the information they have about their condition and about the medication is critically important. There's also sort of this process of the patient engaging in a self-monitoring process. So are they tracking their adherence? And so in our weight management program, we gave them connected scales and we had them weigh themselves daily. And we found that by doing that and providing feedback to that behavior, we were able to increase adherence to their weight management medication regimen. And so in that sense, we utilize two strategies, the self-monitoring as well as the feedback together to drive medication adherence. We can do things like create social norms for people where they may not exist. So thinking or to counter social norms that may exist and thinking about those contexts that people operate in. So for example, in our weight management program, we wanted people to weigh themselves every single day, 7 days a week, because the research said that people who weigh themselves 7 days a week lose more weight than people who weigh themselves 5 days a week, and certainly more than people who only weigh themselves once a week. And so what we did was to create a norm around that by messaging them that people who weigh themselves 7 days a week are more successful and lose more weight. Or we might have messaged them that said, people like you who are weighing themselves 3 days a week lose more weight when they weigh themselves 7 days a week, right? So when people make this change, they see this benefit. And so it actually changes the social norms around them without actually having to put them like into a group conversation or hold a support group. We can actually change social norms in our conversations, and we can see that in a lot of ways. We can create contracts with patients, right? So we call them behavioral contracts to say, can you commit to doing this? Can you commit to taking your medication every day next week? And using those tools to create a system to drive medication adherence. And so you don't have to just choose one of these. You can use multiple of them or try different ones at different times. And so I think the other thing that is really important as part of this is to help people navigate through relapse. Relapse is an incredibly common part of changing behavior, right? So we all find it when we set our New Year's resolution that we're going to exercise every day, right? And then we miss, like you had a really busy day at work and you were up super late and the alarm went off and you just said, I'm not going to the gym this morning. And so when that happens, when we miss a day and we relapse out of our intended plan, right? This is incredibly normal. And what we need to do for people is to let them know that that is normal and then what to do about it, right? So yes, you were tired and you slept in and that's okay. What are you going to do tomorrow? You're going to get right back at it. Or, instead, try taking a walk at lunch, right? We can give people strategies for what to do when their plan doesn't go according to plan, because things never go exactly according to plan. And so we want to help people realize that. I think we also need to help people manage, right, that stress happens and life happens, and that by giving them skills for things like navigating stress and challenging situations, they're more likely to adhere. And that's not just true in weight management, but we talk about it a lot of what are you going to do when you have a bad day? And what are your current strategies and how are you going to navigate through that? And so it actually combines two things. We're going to build stress management skills, but we also help them build planning skills. And so as I've given some of these examples, we can stack them all together and we can create, a whole year-long program, of course, but what we're really talking about here is using any of them in a short interaction with a patient. And so that, some of those examples, when you miss a pill, and it will happen, right? We all sort of have those days. Here's what you do. That can happen in a very brief interaction. And so these do not have to be, you don't have to build a whole app. We don't have to have a whole program. We can use these within the context of an office visit and a conversation with a patient, or a telemedicine visit these days seems to be more common. The other thing that I think has become a lot of part of the conversation with the award of the Nobel Prize to some behavioral economists is those strategies. And so this is a newer part of the behavioral science field. It does not have the same level of research behind it that some of the other work that I just showed does, and that health psychology has been around for decades and decades. But it can be useful in building our mental models to think about some of these newer strategies and how we might use them. And essentially, it's thinking about the fact that people use these shortcuts when they're making decisions, and particularly sort of around these health behaviors. And so availability is this idea that we assess the likelihood of something based on how easy it is to imagine it. And so in medication adherence, what that looks like is patients are more likely to adhere to their heart failure medication right after they've had an event. And the further away from that event they are, the less likely they are to be adherent. And so knowing that, we may deploy different strategies for medication adherence proximal to a major event than when the patient is more distal from a major event. We may need to be aware that the further a patient gets from, being discharged from that heart attack, the more support they're going to need for medication adherence, and adjust our programs accordingly. People value what they have more than what they might gain. And so in weight management, for example, we're trying to get someone to adhere to a diet plan. We may structure that by having a weight loss contract with a goal, and they put money in at the start and they lose that if they don't hit it at the end. And so there are ways of thinking about those kind of approaches. Representativeness is sort of that the patient has a mental model, right? They judge the likelihood of an event when it's similar to something else that they know. And so if the patient sort of has this mental model that medications should be taken in the morning, and in fact, for reduction of side effects, it would be better for the patient to take it in the evening or for other reasons, right? Knowing that patients have these mental models allows us to adjust what we're doing according to those things. So just sort of recognizing that these are kind of some of the things that may be happening in the patient that drive their decisions and their actions can help us build our mental models for thinking about medication adherence. And so with that, I just sort of will close with this sort of reminder, right, that these are multifaceted components that play into medication adherence. And rather than sort of being overwhelmed and feeling like we have to solve all of them in the complexity of healthcare, to realize that there are lots of ways that we can come at the problem and try and move the needle on it for our patients and really have an impact.